Welcome, and thank you for tuning in to Derm Docs, powered by LiveDerm. This marks the third episode of our ongoing series, a program on JAK inhibitors for atopic dermatitis, hosted by expert dermatologist Dr. Christopher Bunick, Associate Professor of Dermatology at Yale University in New Haven, Connecticut. Our third episode today, the quest for itch-free clear skin in atopic dermatitis, new practice-informing evidence, features Dr. Jonathan Silverberg, Associate Professor of Dermatology and Director of Clinical Research and Contact Dermatitis at the George Washington University School of Medicine and Health Sciences in Washington, D.C.
Hi, everyone. Welcome to the LiveDerm podcast series program on JAK inhibitors for atopic dermatitis. Welcome to today's specific podcast where we focus on the quest for itch-free clear skin in atopic dermatitis. I'm Dr. Christopher Bunick, Associate Professor of Dermatology at Yale University School of Medicine. And joining me today is Dr. Jonathan Silverberg from George Washington University. Again, we're going to be discussing the quest for itch-free clear skin in atopic dermatitis and exploring new practice-informing evidence. Jonathan, could you briefly introduce yourself and share your background in dermatology?
Sure. It's great to be with you, Chris. I'm Jonathan Silverberg. I am a professor of dermatology at the George Washington University School of Medicine and Health Sciences in DC. And I chair or run the contact dermatitis program there and head up all the clinical research there.
Excellent. So let's start with some basics, Jonathan. Can you explain what atopic dermatitis is and how prevalent is it in the general population, specifically in the United States? Is incidence and prevalence of atopic dermatitis increasing or decreasing?
Yeah, so there's a lot there. So the prevalence, as far as we know in the US, I mean, it varies very much between children and adults. In its higher relative prevalence in kids, about 13% in the US population, based on studies from National Health Interview Survey and National Health, as well as the National Survey of Children's Health, so which are population-based studies in the US. In adults, it's about 7% prevalence based on data from actually some recent hot off the presses data, even as recent as 2021 National Health Interview Survey shows around a 7% prevalence. So we've got multiple studies that put that 7% number probably is most correct. It looks pretty stable in terms of the prevalence in adults and children. If anything, it might be going up slightly, but not certainly showing any evidence of really dropping. But it's, we have less data around incidence in the US, but it's something that we know prevalence reflects a mixture of both new onset cases as well as just persistence of earlier onset cases.
Yeah. So how would you describe atopic dermatitis to a new family in your office?
Yeah, so a question that comes up quite a bit. It's an immune-mediated disorder. I try to explain it to patients that it's in a sense like an autoimmune disease because the immune system's turning against the skin. But I don't want them to get nervous, like, this is autoimmune like lupus, or right. So I try to differentiate in that respect. But that's the immune system attacking the skin, and that there's a variety of different factors that drive it. I like to explain to them that there are many different triggers, sort of that are contributing factors, but none of them are necessarily the root cause. So that because they always jump straight to the foods and all these other things, and we'll talk a little bit more about that, but. But then for them to understand that this is an immune-mediated disease, and for many, it is a chronic disease and can even be lifelong. And that I don't want to be negative, when I say that to them, but I want to sort of set that realistic expectation because I think for so many over the decades have been told it's just going to go away. And so, this can be lifelong, certainly chronic, and we need to think about developing treatment approaches that will really work for them in the long haul.
Yeah. So when you talk about the immune-mediated nature of atopic dermatitis, certainly a lot of families, when they come in, I'm just curious, when you talk to them, how do you discuss or bring in the atopic triad or this concept of the atopic march and the role of asthma or seasonal allergies? How does that discussion go between you and your patient?
Yeah, so I do explain. I mean, I first start with the basics around the skin disease issues, and it depends really where they are in the course of their disease. If they're a new onset case, sometimes I don't even bring it up. If they're really early in life at that first visit, and I'll save it maybe for a later visit, especially if they get into that more moderate to severe territory. Maybe even at the first visit, I'll bring it up if it's someone who's already got a longer standing case, perhaps more in that moderate to severe category. We know that patients with atopic dermatitis have higher rates of the entire spectrum of allergic disease, whether that's food allergies, hay fever, asthma, eosinophilic esophagitis, et cetera. But that it's not that atopic dermatitis is a food allergy. And if anything, atopic dermatitis increases the risk of food allergies, but not necessarily the other way around. And so I don't bring up so much of the atopic march because I think there's like a whole lot of controversy around, do they really march? Do they not march? But I certainly bring up that the atopic comorbidities are a real thing and something we're going to have to consider. And also a reason why we want to try to achieve tighter control sooner rather than later, because we don't want that long-standing disease to now become a gateway for developing that allergic disease down the road.
Yeah, I think that's well put. So what are some of the common symptoms that patients with atopic dermatitis experience, and how is that going to impact their quality of life?
Yeah, so the universal symptom of atopic dermatitis is the itch, right? And everyone always says, oh, it's the most common symptom. Well, it is, but it's universal. If it doesn't itch at some point, it's not atopic derm. And it happens to be also the most burdensome symptom. Multiple studies have looked at this type of exercise and have shown that the number one symptom across all severities is itch. And even if it's somehow not the number one most burdensome symptom, it's the second most burdensome symptom. So we know that itch is really the big driver for so many patients. With itch, it's not just itch, right? Because they're scratching their skin. Now they get pain on top of that. Now they have sleep disturbances downstream from the itch. They can sometimes have concentration issues, impacts on activities of daily living, all these different things that are happening now secondary to the itch. And then on top of that, you have, of course, the visible lesion component, which is certainly a big issue, especially if they're getting lesions on more visible areas like the head and neck or on the hands and feet, et cetera. We've seen numerous studies that have taught us that atopic dermatitis can really impact pretty much any and every aspect of a patient's life. And, it may vary a little bit by the patient's occupation or by the patient's sort of, hobbies or just lifestyle, but pretty much anything that they do, whether that's being at home or whether that's, working in a factory setting, the atopic derm can really mess with all aspects of their life.
Yeah, along those lines, I remember a particular patient, roughly a 30-year-old gentleman who had really never been able to go into a swimming pool without burning and stinging of his skin. And I remember that, when he had started biologic therapy and his skin cleared, he was very much thankful for just being able to swim without that feeling. And I was curious, do you have an anecdotal story somewhere along those similar lines?
Absolutely. First of all, that swimming thing we see a lot, right? And that's the funny thing about atopic derm, because most patients, I think, are in the boat of the patient you mentioned. Yet sometimes patients swear that the swimming pool makes them better. And it's like, I can't predict when that's going to happen and why one patient goes one way and one goes another. But we've had patients where they're so happy because they can wear shorts, in the summertime, because they have to cover up all the open sores. And prior to treatment, they're socially isolated. They're not able to wear the clothing that they want to wear. I had one patient, one of the worst that I've seen, and I asked him, how does atopic dermatitis affect your life and your work? I asked him, and he said it doesn't. And I was kind of puzzled by that. And I said, well, what do you do? And he said, well, I'm a gamer. And he had no insight into the fact that he chose a career where he sat in a dark room behind a firewall because of his atopic derm. And I didn't even bring up at that point in time, but we got him on finally a highly effective therapy. 4 months later, he got a job. A month after that, he was promoted. 2 months after that, he had his first stable relationship. And so, but sometimes the patients don't even realize how every decision they've made throughout their adolescence and childhood has been to sort of accommodate and cope with their disease.
Yeah, it's a very powerful story, and indeed, this is why we're talking about atopic dermatitis today, is because it continues to make such a huge impact on patients' lives throughout all of dermatology, for sure.
Absolutely.
So let's transition from kind of understanding some of the basics of atopic dermatitis to understanding the current treatment landscape. Can you provide us an overview of the current treatments available for atopic dermatitis, including the topical treatments, traditional systemic therapies, and our more advanced systemic therapies?
Yeah, so there's a lot, and we're very fortunate to have a growing toolbox. We look forward to having even a larger toolbox, but there's definitely a lot to go through. I guess I'll break it down first. When you think about the topical space, we've had certainly the old school topical steroids that we know, and I don't want to say know and love, because I don't think we love them, but we use them. We use them because we have to, because they're cheap and easily accessible. We've got now multiple non-steroidal topical therapies that are at our disposal. We had topical calcineurin inhibitors like topical tacrolimus and pimecrolimus, going back now, more than a decade, a couple of decades now, as topical calcineurin inhibitors. And then, fast forward to 2016, 2017, we had the approval of topical crisaborole ointment as a phosphodiesterase E4 inhibitor, which was approved for mild to moderate disease. And that was really the first major innovation in the topical space for over a decade. But that really opened the door for innovation in the topical space. And then, a few years after that, we had the approval of topical ruxolitinib cream as a topical JAK1, JAK2 inhibitor for mild to moderate disease, which is, in that scenario of topical ruxolitinib, we actually had head-to-head study done in phase 2 showing it to be even more effective than a mid-potency topical steroid cream, triamcinolone. But as good as it is, some complexities there, because we do have some black box warnings around, the use class-wide. Then more soon to be coming into the atopic derm space, we look forward to getting the approval of, but not yet approved, the approval of topical tapinarof, which is approved now in psoriasis, as well as topical roflumilast, which is approved in psoriasis. And we're looking forward very soon to get those approved in atopic derm. So a lot happening in the topical space. When we go into the injectable biologic space, the first of those therapies to be approved in atopic derm was topical or injectable dupilumab subcutaneously. And that was approved back in 2017 for moderate to severe disease after patients have an inadequate response to topical therapy. And that blocks the receptor for both interleukin-4 and interleukin-13 signaling, and really revolutionized the field. It was the first approved systemic therapy for the disease, good efficacy, clean safety, and has really stood the test of time in the real world. And that just opened the floodgates of opportunity for new therapies as well. Shortly afterwards, we had the approval of injectable tralokinumab, which is a biologic that targets the free IL-13 cytokine. So similar mechanism conceptually, a similar class, but is one that offers us yet another option to think about, to potentially cycle through the biologics as well. And also approved as potentially a first-line biologic therapy after having an inadequate response to topical therapy. And then we got multiple, right? Depending on where you are in the world, multiple oral JAK inhibitors, abrocitinib and upadacitinib, both as oral once-daily JAK1 inhibitors that were approved both in the same day, going back, I think it was a few years back now. And both, with 2 different doses approved with, and really both at their highest doses, really setting the benchmarks in the field for efficacy there, but also do come with laboratory monitoring and potential, class-wide black box warnings to discuss with patients. So something for everyone, but each one with its sort of strengths and weaknesses. One is an oral, which is often preferred by patients. One's an injectable, which is less so, but they may be a little bit cleaner in terms of their labeling. Right? So there's definitely a lot of nuance when you're discussing these things with patients.
Yeah, no, that's a great summary of the field. I think that You and I have talked about this in your network meta-analyses where you compare all of the systemic agents for atopic dermatitis. We're going to talk more about standards of care over the next few minutes. But when we think about EASI 90 response in atopic dermatitis patients, and if you look at, say 40% threshold of response of EASI 90, there's only 3 medicines that beat that 40% threshold, right? The upadacitinib 30 milligram dose, the abrocitinib 200 milligram dose, with the caveat that that's at 12 weeks, not 16 weeks. And then the upadacitinib 15 milligram dose. I like to think about this. We have the Paris Olympics coming up this summer. I like to think about that as the gold, bronze, and silver based on the network meta-analyses. And I think, we're going to talk about level up and how that data sort of actually supports or is consistent with your network meta-analyses.
Yep. I completely agree. And I think we now have multiple network meta-analyses that have shown pretty much the same types of results. There's always some caveats to doing these cross-trial comparisons in the network meta-analyses because, you don't always have head-to-head data. But in the case of both abrocitinib and upadacitinib, we do have head-to-head data against dupilumab. And it really recapitulates the findings of the network meta-analysis. It shows us that sort of that relative differential in efficacy holds up, and that even in well-designed head-to-head studies, especially at the higher doses, upadacitinib and abrocitinib both show statistical and clinically meaningful superiority compared to dupilumab.
Yeah, and that's a very important thing for practitioners to know so that they can also make good decisions for their patients. So we get a little bit ahead of ourselves. That's my fault. But let's back up and just focus on some of the challenges. So we mentioned all these therapies. What are some of the challenges you see with these treatment options in terms of efficacy, side effects, patient adherence, accessibility?
Yeah, so I think all of the therapies that I mentioned all offer good options for patients. I think the hard part that we face just at a high level is we don't really have any biomarkers or any prognostic markers, any way of really sort of predicting like who's going to do well with one drug or another. So there's certainly a little bit of a lot of a component of trial and error that comes up. And so, I think everyone deals with that a little bit differently. You try one therapy, maybe you have one go-to as your starting place, right? And if you do well, great. And if not, well, you switch to some of the other therapies. And I don't think there's necessarily a right or wrong about how to sequence. And nor do we have really any data to give us an evidence-based guidance around that. But I think that is a challenge, is that as good as these therapies are, they don't work on 100% of patients, super well, or give us those super responses in everybody. And so, we try it, they don't work well, we switch, or we think about how to optimize response. We do encounter, safety and tolerability concerns with all of the therapies, with the topical JAK inhibitors, with topical ruxolitinib, as much as it's a topical and it's pretty clean in terms of real world use and even in the trials. But the FDA took a sort of very draconian blanket approach to label anything related to JAK with the class-wide black box warnings, even if we don't fully believe in it, right, in the real world. So we still have to have that conversation around the use about the black box warnings around the use of topical JAK inhibitors with patients. And that sometimes scares patients, right? Even if we're not particularly worried about that. So that's a challenge that can sometimes come up. With the biologics, just sometimes patients just don't want to do shots. I mean, it's a real issue. And there's a range, right? There's patients where, it's funny, like I have patients who'll say to me, doc, like they're all surprised, like, they're like sheepish to say, doc, I really don't like shots. And I answer them back now jokingly, that's good. That means you're normal, because who likes a shot, right? But there's patients who don't like shots. And then there's patients who say to you, I've had multiple patients say, doc, I'd rather die than take a shot. And I quote them, right? And so then I'm like, okay, then we're not talking about shots anymore, because we've got another option, right? We've got PATH with orals, right? So that's one scenario that can come up. Sometimes we do face adverse events with even the type 2 biologics, like dupilumab and tralokinumab, where they're getting, the conjunctivitis, the ocular surface disease, or maybe they get joint pains. We've published case reports, rare scenarios where they even get this sort of immune shifting towards getting psoriasis that comes up and stuff. So How common is this? It's certainly not the majority of patients, but it's common enough that we navigate this in the real world with regularity. And then you've got the oral JAK inhibitors, which, as we mentioned, are incredibly effective and incredibly fast and have the amenities, the niceties of being oral. But on the other hand, right, there is laboratory monitoring, and there are, boxed warnings that you have to navigate in those conversations with patients and thinking about the right patient selection there. So it's, each one has sort of a pro or a con that the others don't. Now that's, in a sense, a good thing, but it leads to a little bit of the complexity of when you're discussing it with patients, you kind of have to lay it all out there to try to match the right drug to the right patient.
Yeah, definitely. In the 2024 atopic dermatitis AAD guidelines, there is a strong recommendation against the use of systemic corticosteroids. Where do you stand on the use of systemic corticosteroids for the treatment of atopic dermatitis with today's treatment landscape?
Yeah, so even before the guidelines, I was one of those who really exceedingly disliked oral steroids and injectable steroids for that matter as well. I mean, at least intramuscular steroids. So the guidelines are very much in line with my thought process. I really work hard never to use them just because I've had so many scenarios of patients where just whacked out adverse events. And I'm not saying it's everyone. We know we could probably get away with it from time to time, but patients with bone mineral, 20-year-olds with bone mineral density of 95-year-old women, patients with spinal compression fractures due to osteoporosis, homicidality, a female patient who wanted to literally kill her son and her husband when she went on steroids. So this is real. I mean, the side effect profile is abhorrent. So I am a strong fan of not using them wherever possible. I know some are a fan of using, they'll say, well, yeah, I don't like to use oral steroids, but I can get away with using injectable steroids. I've had patients with the bone mineral densities, Cushing, septic colitis issues with intramuscular steroids. So I would lump intramuscular. Maybe it's a little bit better than oral, but I put it up there. So, and the challenge is, even if you can, quote, get away with their use, you have to recognize they're never going to be the ideal long-term solution, right? By definition, we're only going to be using it sort of in these short-term courses, right, which is never going to address the long-term needs of the patients. And then I think one other point that's important to know is there's this sort of, myth in the field. Well, if I just do a 3-week course of steroids or a 1-week course, I won't have any problems. It's the long-term use that's the problem. Well, there was a publication in, I think going back was in BMJ, British Medical Journal, going back, I'm trying to remember, maybe about 5 years ago, that looked at all indications throughout the UK data set and found that in a massive data set, even short courses, less than 1 month course of systemic steroids was associated with higher rates of sepsis, fracture, and venous thromboembolism. And that's the 3-week course or the 1-week course of systemic steroids. So anyone who wants to tell themselves and sort of pretend like this doesn't happen, we have hard data to show that it does. So I think the guidelines are justified. Now, I was involved in the guideline process. Personally, if it was up to me, we would have put a hard contraindication to doing them. But we knew and we recognized that, unfortunately, due to insurance reasons, that sometimes you're desperate and you have to turn to them. So we acknowledge that there might be some need here or there, but we really are not fans of their use.
Yeah, and I think you and I talked, a year ago at your RAD conference that I'm definitely anti-systemic corticosteroids for atopic dermatitis as well. And it seems to me that the rapidity of onset and the ease of accessibility and the ability to take an oral JAK inhibitor, why shouldn't oral JAK inhibitors just replace the use of these systemic corticosteroids? It seems very logical to me.
I completely agree. And I think, from the paper that you published, looking at the comparison between sort of the trial data for the JAK inhibitors versus what we know already about systemic steroids. I mean, in a sense, it was the most obvious thing in the world, yet really most weren't thinking about it, weren't aware of the data. So, it was such an important contribution to the field. But so much of this conversation that's now happening around the JAK inhibitors with safety is like, it's almost weird, because people are like talking about some of these side effects now like it never happened before. They're whopping, effect sizes and huge signals for the systemic steroids, and yet everyone completely ignored that over the decades, like it didn't happen when there was clear data that it did. So I think it's very important that we don't just like ignore the side effects that are well established from some of these older therapies and only focus our attention on the new stuff without having really context and history to what has gone on in the field.
Yeah, I like to summarize the JAK inhibitor safety as, a couple of years ago, a lot of worry, and as more and more long-term safety data comes, more reassuring does that safety become. I think is a simple way I like to convey the safety of the JAK inhibitors.
Yeah.
So with that said, let's dive into the Level Up study that compares the upadacitinib, which is an oral JAK inhibitor, to dupilumab, our injectable IL-4, IL-13 biologic. So can you describe Level Up's design and its primary objectives?
Yeah. So the Level Up study is, just to give a little bit of background and context, it was a very important study in terms of the need. We had for upadacitinib the Measure Up 1 and Measure Up 2 studies, which were sort of the flagship monotherapy studies for upadacitinib that showed very clearly excellent efficacy for both the 15 and 30 milligram doses of upadacitinib compared to placebo, the 30 better than 15, both very fast. But when in those studies, when patients got 15 milligrams or 30 milligrams, they got those from day one all the way through to that 16-week treatment period. Well, fast forward, and then we had another study that was done, the Heads Up study, that looked at upadacitinib as a 30 milligram dose, the higher dose, compared to dupilumab, showed superiority, as we were discussing a little bit earlier. Well, the FDA, when they approved the upadacitinib in atopic dermatitis, they gave us both doses, the 15 and the 30, as approved doses, but they also put in their sort of arbitrary recommendation: start at the 15 milligram dose. Patients do well, great. If not, then you have the option of stepping up to the 30 milligram dose. And in a sense, the FDA went a little rogue there, because they made a clinical recommendation for us that actually wasn't studied that way, because what was studied was 15 pure or 30 pure, not this 15 with the option of stepping to 30. So the Level Up study, a very important part of that was to really understand how that on-label 15 with the option of stepping to 30 performed. But there are some other important niceties and background points to the study, because one, we also have the head-to-head component against dupilumab, which, how cool is that, right? I mean, so many times we crave the head-to-head studies, but we rarely get them. And so here we have that head-to-head data, understand how it works against sort of one of the other drugs as a benchmark. And then I think really importantly and provocatively, we've seen a lot of recent health outcomes research and observational research that has shown that the importance of not just sort of achieving these modest or moderate endpoints like an EASI-75 or just achieving a 4-point response in itch, but that patients really are craving and get major upgrades in terms of quality of life improvement when they can get to more deeper responses like EASI-90 responses, EASI-100 responses, or when they get to itch-free states like NRS Itch 0-1. And so the Level Up study built in, really, to my knowledge, the first time ever, this composite endpoint that looked at getting to this EASI-90 response, this major clinical improvement in the EASI score, as well as getting to this sort of itch-free state with the NRS Itch 0-1. This is not an easy endpoint to achieve. It is an incredibly hard endpoint to achieve, but it's certainly sort of the promised land of what we think about. At least for me, I always tell patients my treatment goal is to get them clear skin and itch-free, and I think that's sort of that best composite endpoint to get there. So we've got a few of these key pillars now coming together in this study. And I think it really fills in a lot of important insights into the performance of upadacitinib in the field.
Yeah, I think that, very well said. I mean, here we have really for the first time this composite, really stringent endpoint of EASI-90 and itch. of 0 or 1. And so I think that is a tremendous important point to stress to our listeners, that this is a really composite, stringent endpoint that's addressing kind of from the clinical side, the extremely clear skin, almost clear or almost clear if you're doing like an investigator global assessment scale, and this itch 0 or 1, basically, when you think of the itch numerical rating scale, I like to use the analogy. A lot of times, dermatologists, if a patient is an itch of 8 and we get them down to a 3 or a 4, we pat ourselves on the back thinking we did a really good job. But really, the Target Derm registry data is now telling us that going from an 8 to a 3 actually does not get patients to the quality of life that they really need. That even just itch of a 2 compared to a 0 or a 1 can be upwards of 30 or 40% difference in quality of life. And, when I saw that data, I think that to me, that was some of the most powerful data over the last 12 months for me personally, because it meant that the patients I thought I was doing a good job in, I actually wasn't. And so what Level Up is now doing is going to a whole nother level to say, we are going to really look at the skin and the itch and the totality of the patient's quality of life. So I think it's really important. So what were some of the key findings from the Level Up study with regard to itch reduction and skin clearance? How well did the upadacitinib 15 milligrams do compared to the dupilumab?
Yeah, so for the primary, that composite stringent endpoint of getting to both that clear skin and the itch-free, about 20% of patients achieve that with upadacitinib compared to about 9% in the dupilumab arm. So more than double the patients achieve that kind of really stringent endpoint at week 16 with upadacitinib compared to dupilumab. And when you look at the kinetics, I mean, you already start to see this, composite endpoint being achieved by week 4 for upadacitinib, where it really doesn't start to, show up with any demonstrable numbers to more like week 12 or week 16 for dupilumab. So at all time points, the upadacitinib is showing superiority for this composite endpoint compared to dupilumab. But, even if you look at sort of the old school, if you will, or composite boring endpoints of EASI 75, you see that upadacitinib is showing statistical superiority over dupilumab at all time points as well, and is showing a much faster response than dupilumab. And likewise, if you looked at EASI 90 by itself or EASI 100s, I mean, how cool is that we're able to even talk about EASI 100s, complete clearance of the skin. And you're seeing that upadacitinib clearly beats dupilumab in those endpoints as well. I think notably also, especially when you look at like the EASI 100 numbers, there's no evidence of a plateau. So that suggests that with continued dosing, there's probably even more efficacy to be gained. And that's probably true for both of the drugs. But recognizing that atopic dermatitis is certainly not a purely 16-week disease, and that for many patients, they will require longer treatment periods. You look at the speed. I mean, this has been something we've seen already with upadacitinib, is just how quick it is already by day 2 for itch and some of the previous studies. But here, when you're doing this comparison at week 2, week 4, week 16, it doesn't make a difference. When you look, you see very clearly that upadacitinib is showing a faster response and a more robust response across itch, really across all those time points out to week 16. And stay tuned, there's more data beyond week 16 to be coming, but we need time for all those analyses to be performed. I think one thing that's fascinating about the analysis is, all right, so we get these sort of conventional endpoints, and sometimes you think like, well, maybe the drug's just working well in some of those like less severe patients, and you're always left wondering like, who are those patients who are going to be those super responders? So kudos to the sponsor, because they developed or they did these stratified analyses in post hoc to really understand, like, are there some like maybe the moderates just do much better than the severes, and the severe patients just don't do so well. And what we actually saw was that for upadacitinib, the efficacy seems to be just as good for severe disease as it was for moderate disease. Whereas when you look at dupilumab, the more severe they were at baseline, the less effective it was. It's a fascinating observation. I'm not sure I even fully understand the why behind, some of the differential effects there. But I think it shows us that really across all patient severities, upadacitinib is working quite well with that on-label dosing.
Yeah. No, I agree. That's a very, very interesting observation. So in your expert opinion, how do the outcome measures used in Level Up compare to previous studies or current treatment standards? Is this combined or composite endpoint aligning with optimal treatment targets for atopic dermatitis?
Yeah, so certainly this composite endpoint, I mean, I think was guided. It was developed to be in line with the treatment, targets that have evolved based on all the qualitative and patient-based research and other observational studies that have been done. So it certainly is in line with that. And I think it is really frame shifting for us how we should be thinking about setting our targets. That said, it's not everyone who's going to be able to achieve that, perfect state of itch-free and completely clear skin. So I think it really changes the bar and reframes how we should be thinking of setting the bar. But I think we also have to set realistic expectations with patients to know, like, there's going to be a subset of patients who are going to get this incredible clearance, but not everyone will. But even if you don't, you still can do fantastic, where you'll get maybe an easy 90 by itself without the itch-free, or itch-free without the easy 90, or you're still getting an easy 75 or an NRS4. I like to just give that range of efficacy when I'm discussing things with patients, because I don't want to overpromise. I don't want to underpromise. I want them to know that there's sort of a range and a little wiggle room of where they may land.
Yeah, I was always taught under promise and over deliver.
Right.
So let's talk about how Level Up impacts clinical practice, or how it may impact clinical practice going forward. So here, this study leverages 2 on-label dosing regimens for upadacitinib to achieve itch-free and rash-free status. But so how can these results from Level Up be integrated into current clinical practice to improve patient outcomes? What should the dermatologist or provider who's listening to us today, what should they take from this study in terms of how they practice their medicine?
I think there's a number of important clinical take-home messages. Some of it is just sort of like background stuff related to the disease, and some of it is very specific to upadacitinib. In terms of the background stuff related to the disease, sort of as we were discussing beforehand, the literature has taught us, agnostic to upadacitinib, but the literature has taught us the importance of really trying to get patients to clear and trying to get them to itch-free. And I think it's highly relevant in how we interact with patients, because let's be honest, when you're running 40 minutes behind in clinic, and unfortunately, at least in my practice, I don't know, maybe you're running much faster than me. I'm sometimes behind with these complicated patients. And when you've got a patient, you ask them, let's say they're on some therapy, whatever, a topical, biologic, doesn't make a difference, whatever therapy they're on. And you ask them, how are you doing? And they'll be like, good. Well, you've got 2 options there. You can get the heck out of the room as quickly as possible because they gave you that opportunity. So, oh, you're doing well. Okay, I'll refill the medication. We're out. See you in 6 months, or follow up as needed, right? And let's be real. Many take that path because you want to catch up in clinic. You want to get out. You want to get home on time. Or you could take the time to ask that 1 additional or 2 additional questions. How much better are you doing, right? What's your itch? On a scale of 0 to 10, where'd you get to? And they'll tell you, I got maybe a 10 down to a 4 or 5, right? But as you pointed out, a 5 isn't that good, right? It's better, but it's not that good. How's your lesions? Well, actually, and they roll up their shirt, or they roll up their pant leg, and like all of a sudden, like, oh, actually, it doesn't look so bad on the face, or the hands maybe look better, but there turns out there's quite a bit of active disease. And if you take that time, what you find out is, yeah, they're doing better, but they're by no means optimized. And so I think that's the lesson that we learned from all this research, is that we should aim higher with whatever therapy you're going to choose. That we should aim higher and try to understand a little bit more about what their itch is doing, just how clear are they getting on their therapies. So that's sort of the high level for me on the value of that composite endpoint, and really thinking about that on day-to-day basis. Yeah. In terms of the specifics around the drugs, I think this fills that important gap to show us with even that on-label use, not just doing 30 out of the gate with upadacitinib, but with that on-label regimen of 15 with the option of stepping to 30, that has also showed superiority to dupilumab. And I think that becomes important with that shared decision-making conversation, because when you're discussing different treatment options to patients, the logical question they're going to have, and let's be real, the logical question we have is, well, how do they compare to each other? And here we've got the data now to show us that in that sort of who's the gold, who's the bronze, right, that the 15 to 30 is clearly beating, on efficacy and on speed, and depth of response is really beating, many of, if not all of the other biologics out there.
Right. So aiming high. So it sounds like you believe that the Level Up study does in fact raise the standard of care in atopic dermatitis. Is that a factual statement?
I think so, yes. Or at least it certainly confirms that or reaffirms that.
Sure. So what strategies would you recommend for educating patients about new treatments and ensuring this clear communication to manage expectations and adherence to these new advanced regimens, such as JAK inhibitors?
Yeah, so I guess I'll start with the adherence part. Adherence is an important part of the conversation. And let's be real, I think we don't talk about it enough in dermatology, especially with all of our like twice daily topicals that we pretend like patients are using all the time perfectly. And I don't know about you, I have eczema. And I'm just in general, I'm the worst patient possible. I can't remember to take azithromycin for 3 days. And I tell that to patients because I give them that permission. I feel like sometimes they're embarrassed to admit it. I'm like, look, some patients are going to remember to take it once daily and some are not. And then the patients will say, I take my blood pressure medication every day. This is not going to be a big deal. I'll just throw it into my pill box. And others are like, I really don't remember to take it. Well, that's important because if they can't remember to take it, it may not be the right therapy for them. There's all kinds of discussions around like how to navigate injection issues when it comes to like the biologics and how to navigate and tolerability issues and managing anxiety around injections and stuff like that. And that's like a whole different discussion, but something that's, you kind of have to assess just how, needle phobic are they in that conversation and help them navigate some of that. There's certainly a lot of things to even think about when it comes to patient selection with these different therapies, right? In terms of background risk factors and review of systems and stuff like that. So there's certainly a lot of different considerations, and it's going to vary by the individual treatment that you're, pondering.
Absolutely. So let's kind of move into our final segment, looking at kind of future directions and where this research is headed. I think you sort of alluded to this. But what are some of the ongoing or future research efforts that are building on these findings of Level Up study? I think you mentioned that there's a second period to this Level Up study, in fact, which is a switch period from kind of those who had an inadequate response to dupilumab at week 16, switching to upadacitinib. So what can you tell us about some of the data that's going to be coming later this year?
Well, I think that's going to be, very important for us to see. We don't know yet, right? I mean, so that's for full disclosure, right? We just need to collect all the data and analyze it. But we do have some, I think, inkling of what it's going to potentially show, because from the Heads Up study, which was the head-to-head of the 30 milligram dose of upadacitinib versus dupilumab, there was also this kind of switch period where those patients who were in the dupilumab arm would then get switched to upadacitinib. And there was no washout there. So it's an interesting thing because it's a little bit of an additive period in a sense, but you see this big spike in efficacy that happens when they go from dupilumab to upadacitinib. And I think that informs us that for some patients who are, maybe even if they're doing well with dupilumab, they could potentially get even more robust responses with upadacitinib. And certainly in patients who may not be doing well with dupilumab, there's certainly an opportunity for them to do well with upadacitinib. But that's with the 30 milligram dose, which officially would be off label to start with that.
Right.
So we're eagerly awaiting the data for this on-label dose switch.
Yeah. And just to clarify that this data from the switch will actually use this very stringent composite endpoint of EZ90 and Itch0R1. So we're going to get a really stringent view or a very detailed view at how well this head-to-head comparison performs in this switch period.
Absolutely.
So can you discuss some of the technologies that are emerging or therapies that are on the horizon that you think could really impact management of atopic dermatitis in the years or even decade to come?
Yeah, I don't think we have enough time to go through everything that's in the pipeline because it's enormous, which is a great thing. And we know in the world of drug development, a lot of stuff just doesn't make it. So we'll have to see where some of that lands. Some of it is really cool, novel, potentially transformative technology. But until we see the clinical readouts, we won't know. But I think what is very important is there are two that are really close to approval. And it may be already, by the time the audience is listening to this, may already be even approved. But one is lebrikizumab, which is a biologic that binds to the free interleukin-13 cytokine, in a sense similar to dupilumab and tralokinumab, although some key differences in terms of potentially dosing and binding affinity and duration of effect. And so that warrants its own conversation, but that is now approved in a number of countries around the world, and we look forward to getting that within the next few months, hopefully, in the US. And then we also have nemolizumab, which is a biologic monoclonal antibody that inhibits the interleukin-31 receptor, and that is, interleukin-31 is thought to be incredibly important in the itch of atopic dermatitis, as well as other effects. And so this, the data readouts look good, and it's something that looks like it's going to have a particularly fast response on itch. It's approved in Japan right now at a higher dose, but we look like we'll probably get it in the US, probably for prurigo nodularis first, if I had to guess. Although I don't know if that's 100% clear yet with the world of the FDA, but probably by the end of this year, we should have nemolizumab approved for PN, and then for atopic derm probably in 2025. So in the next 12 months, two new biologics for us to play in the sandbox with, which will obviously be very cool. Then there's a lot of stuff that's sort of earlier generation, and I think probably one of the most hyped up classes is the OX40 ligand class, which is something that, until recently, no one was really talking about that. We know it's one of these co-stimulatory molecules and interactions that's very important in a number of different points in the life cycle of a lymphocyte, but maybe extremely important in atopic dermatitis. And so now we have multiple therapies that are studying this class, and really understanding how well it's going to work. Something fascinating, without getting into the weeds of some of the data readouts, something that's just very fascinating about that class is it has shown a very long tail of response. So even after they come off the drug, some patients really are maintaining clearance for a long time. So that raises some fascinating questions about, could there be this sort of a concept of remission or long-term response? I think we still have a tremendous amount to learn, but I would argue the future is very bright in terms of the therapeutic pipeline for this disease.
Yeah, what's really interesting kind of about this OX40 ligand pathway is there's already bispecific antibodies in development using this pathway and other traditional cytokines for atopic dermatitis. So they're not even here yet for use, and yet there's already the next generation bispecifics incorporating these types of targets. So it's certainly a very interesting future to come. So to wrap up, Jonathan, could you summarize some of the key points we've discussed today and provide any thoughts for our listeners about the atopic dermatitis space?
Sure. So, we talked, I think, about a lot of different points. Atopic dermatitis is a complex disease, and it's one that there are multiple facets, multiple domains that impact patients, certainly from a quality of life perspective, but also recognizing, even just as it pertains to setting treatment targets, there's such a primary importance around itch, and not just getting the itch a little bit better, but trying to get them itch-free. But also recognizing that, it's dermatology, right? It's skin disease. The visual appearance matters. The lesions matter. So we want to get the lesions clear as much as possible as well, and set the bar higher. We may not be able to get there, but that doesn't mean that we shouldn't, really try to do what's best for our patients and put them in a sort of, put the best foot forward. So set the bar higher. Know that you can get there with our therapies now, and that with more coming. And really take the time to explore treatment response and understand, when they say they're doing better, how much better? Quantify that, understand, because there's probably a lot for many patients. There's a lot that we're leaving on the table, and we can do better on a day-to-day basis there. And stay tuned, because as much as our toolbox is really cool and growing, it is growing even faster. And there's just so many new things that are in the, in the not so distant future that we may be able to use and transform the treatment of our patients.
Well, thank you today, Jonathan, for joining us and really sharing key insights into understanding this quest for itch-free, clear skin and atopic dermatitis. And I'd like to thank all our listeners out there for really tuning in and being a part of this Live Derm podcast series titled Program on JAK Inhibitors for Atopic Dermatitis. We hope you'll come back and continue to listen with us. We're only halfway done. This is the third episode out of 6 that are coming. So we look forward to sharing our next episode with you in the future. But for now, thank you, Jonathan, for really such an insightful and educational program.
It was a pleasure. Thanks very much, Chris.
Stay tuned for our next episode in this series featuring Dr. Ruth Ann Vlegels. Thank you.